All right, let's talk about how we diagnose kidney issues, whether it's kidney failure, acute kidney injury, what have you. Okay. Um, these are the two main things that we do when somebody comes in, whether you're going to your doctor's office. I know that I often will say, oh, someone comes in to emerge. That's just because that's my experience, but you can also do this in a doctor's office. So when somebody comes in complaining of symptoms that might be related to kidneys, we immediately will do a urinalysis and a blood test. And we've talked a lot about this, what we're looking for here. In the urinalysis, we're looking for anything that shouldn't be there, that is there. So your protein, hemoglobin, myoglobin, crystals, casts, anything, any sediment or what have you that um, should not be in the urine that is there. Yeah. And so then in the blood work, this is going to tell us what is in the blood that should have been excreted by the urine or by the kidney, in the urine. And our two biggest tellers here are blood urea nitrogen, or BUN, and creatinine. I'm not sure if your prof or whoever is whatever exam you're looking at taking is requiring that you know these levels, but if in real life creatinine is it's much less cut and dried than this. There aren't really like these hard and fast limits. You get to recognize what's very, very high, but a lot of older people who have had kidney injuries in the past or who have had some permanent damage will have a rise in their creatinine that kind of just is always there. Hopefully it's not, 400, but anyway, it's not as black and white in real life, which I'm sure you're learning in nursing school is kind of the case a lot of the time. So anyway, that's for that. In terms of imaging, so always somebody comes in with any kind of urinary complaints. We do blood work, we do urinalysis, and an ultrasound. The ultrasound will show us kind of the basic anatomy and function, like is it, for example, if it was really, really swollen, it can show you like what the kidney actually looks like, right? But in terms of perfusion and blood flow, your best bet is a CT angio. And that's what this kind of looks like here. It's where they put in a little bit of contrast and you can see how the blood is getting through, how it's getting to the kidneys, the kidney cells and what have you. And it's the renal biopsy. I mean, again, because I'm in Emerge, we definitely don't do that in Emerge. I also have done some work in a procedures clinic and haven't really seen a lot of renal biopsies, but that would be quite a bit further down the road where they would go in and pull out a piece of the kidney, literally, like they'd pull out a little chunk of tissue and then they'd look at it under a microscope to see what's going on with it. It's important to know that we don't usually do MRIs when we suspect kidney function issues, and that's because the contrast dye that you use for an MRI, it is very, very nephrotoxic. So it's already it's already not great for your kidney. We don't want to cause any more harm. Okay. So let's talk a little bit more about the urinalysis and kind of what we're looking for in the urinalysis. I believe I have another slide here on urinalysis. Yes, okay. So let's look at this part over here first. So always, whenever you do urinalysis, and many doctors' offices, clinics, emergency departments, I've never seen it on a unit, but that doesn't mean it's not there, have a way for you to do a urine dip. And so what that means is you do a urine sample, and you have the sample in the little jar, and you actually you run the test yourself. You dip kind of a little piece of paper in it, you put it into a machine, the machine prints out a bunch of information. So you're holding on to that bottle of urine, right? You need to be looking at the urine. So you want to know always, I know you guys have probably gone through this in your assessment classes and whatever, but things like color, odor, sediment, those are all things that you need to note, right? And one of the signs of an acute tubular necrosis is that it will be kind of a muddy brown color, and there's like little granules in it. Blood or myoglobin, it can look anywhere from like pinky orange to like brownish colored. Protein you won't see in the urine, but it will come out in that little printout. Sorry, same with blood. There can be blood that you can't actually see in the urine, but it's there. Casts, I don't think that comes out in just a dip, so that would have to go to the lab. White blood cells you would not be able to see visually, but again, it would come out in a printout. So, and I wouldn't worry about this. I'm not really sure even why this is here, why anybody would be drinking antifreeze, but clearly if you see that, that again is not going to come up on your urine dip. It's going to have to go down to the lab. So the other thing that sometimes will come up on a dip, but usually is in the lab work, would be your specific gravity and your urine osmolality. I have never in my life memorized these numbers. I'm not entirely sure, you know, when you get a printout, it will tell you high or low, right? So really all you need to know is what it means if these things are high and what it means is if they are low. So both of them are indicators of urine concentration. So if it's high, the higher that number is, the more concentrated the urine is. And what that means is the body is retaining that fluid. Instead of excreting it, it's retaining it. Either that or you're extremely dehydrated and there just isn't water or fluid to add to the filtrate that's coming through the kidneys, right? But either way, if the urine specific gravity or osmolality is high, it indicates it's concentrated urine. And so you may have oliguria where you don't pee very often, or you may have anuria, or you're peeing very little amounts, and so on. If that number, urine osmolality or specific gravity, is low, that means the urine is very, very diluted. This you will actually be able to see when you're holding up that container. You know what it's like when you don't drink all day, you go to the bathroom, it's very concentrated. If you drink a lot, your urine is very diluted. So when those numbers are low, it's indicative of too much dilution of that that filtrate, right? And so the patient will experience polyuria. They'll actually go to the bathroom quite a lot. So let's talk about the blood work here. So I hate this and I'm so sorry, but there really isn't anything to do but memorize these numbers. I promise you that certain of these numbers will become like, you'll know them like you know your own middle name. Like it's just, you'll know them so well. For me, sodium, potassium, creatinine, like these things come up constantly. They're just you're constantly using them. White blood cells, red blood cells, hemoglobin levels, and so on. So here we're looking at electrolytes in the blood. This isn't a CBC, these are lights. See, the creatinine number is a little bit different here. Doesn't really, again, 133, when you get upwards of 150, you got to start looking at the kidneys. Potassium 3.5 to 5, really important to know. Sodium 135 to 145, also really, really important to know. Albumin actually is just give me 1 second, because I don't think I actually have another slide about albumin. So albumin is it's a very large protein. And it's made in the liver. It's used to help to maintain osmotic pressure. If you remember back in your fluid balance or acid, whatever, we did acid-base balance and fluid balance in the same unit. So sorry if I'm confusing you, but if you remember, it keeps that fluid. It's a very large protein, so it keeps that fluid from leaking into the interstitial spaces, out of the vascular space. It's normally reabsorbed in the kidney, so it goes back into circulation, right? If that if it's not being reabsorbed back into the system, it's going to come out in the urine, right? So the serum albumin would be low, but you'd have protein or albumin in the urine, okay? I'm not sure that you need to know all of those details, but I find more is better. And the more we talk about this stuff, the more you understand, the easier it is to answer these questions when they hit you, either in class or on the NCLEX. And yes, we'll move on to nursing care in a few minutes.